Pathophysiology, we already started telling about the Campylobacter jejuni, right? So the lipo-oligosaccharide of the Campylobacter jejuni is similar to the ganglioside of the peripheral nerve membranes, right? So to confirm whether our approach is correct, to confirm whether our theory is correct, so what they did is they tried this in laboratory. Okay, they took some rabbits and they started injecting these rabbits with ganglioside lipo-oligosaccharides. Okay, so what happened is when they injected this lipo-oligosaccharides, this rabbit developed something called, which is related to GBS. Okay, so when you injected this lipo-oligosaccharide, even the rabbits developed features of GBS. Okay, so passive immunization of rabbits with these ganglioside-like lipo-oligosaccharides led to flaccid tetraplegia, similar to the acute motor axonal neuropathy variant of GBS. So almost we have confirmed that this is because of lipo-oligosaccharides of that particular infection. Okay, so these ganglioside antibodies have different peripheral nerve targets. So understand, if it's only single nerve point, if it's only single area of action, if it's only single mechanism of action, then all GBS should present the same way, right? But we have various variants of GBS. Okay, I'll explain you various variants. It's totally different also. So how come a same pathophysiology produces different variants? It's basically because your antibodies, the cross reaction between antibodies, have different peripheral nerve targets. Okay, that is the reason why we have various variants of GBS. Okay, for example, anti-GD1A antibody binds to many areas, the paranodal myelin, nodes of Ranvier, and the neuromuscular junction. Whereas if you give me GM1 and GQ1B antibodies, they bind either to the peripheral nerve or to the junction alone. Okay, so sometimes it could be more diffuse, or sometimes it could be very selective. Okay, these different peripheral nerve targets play a role in heterogeneity of the clinical presentation of your GBS, right? So certain ganglioside antibodies have specific presentation as well. For example, if you find there is an anti-GQ1B antibody, it's more likely a Miller-Fisher syndrome. Okay, if you find anti-GM1 antibody, it is axonal motor neuropathy. If you find anti-GT1A antibody, it's possibly a pharyngeal cervical brachial variant. Okay, if you ask me how much is associated, I would say the anti-GQ1B antibody is very highly associated and more specific to Miller-Fisher syndrome. The other antibody association is actually a weak association. It's very weak association only. But if you ask me what's a strong association, it's Miller-Fisher syndrome versus anti-GQ1B antibody is very strong association. Okay. So in history and physical examination, as far as we know, when the patient presents with this ascending weakness, that is when we think of this GBS, right? So besides having this kind of flaccid ascending weakness, of course the areflexia, patients also tend to have something called as a non-length dependent sensory symptoms. So what is non-length dependent sensory symptom? Okay, basically this is an ascending weakness, right? For example, in your legs, in your lower limbs, the nerves is very long, right? Compared to the upper limb, the lower limb nerves are very long. So you have a lot of area for the antibodies to attack, right? And moreover, it requires a lot of area for the nerve impulse to travel, right? When a larger area is there, a lot of areas affected, so that is the area where it gets flaccid paralysis first. Okay, this is called as length dependent motor symptoms. But for sensory symptoms, it's non-length dependent sensory symptoms, meaning it is not must that the larger nerve or the longer nerve should affect it. Okay, non-length dependent meaning it is not must for a lengthier nerve to get affected first. What I'm trying to say is, even in GBS, if you ask me about sensory path, sensory symptoms, sensory involvement, it can be involving the upper limb first and then the lower limb also. Okay, which is completely contradictory for the motor symptoms, right? In GBS, the motor system starts from the lower limb and then ascends towards the upper limb. But sensation part, from the sensory part of view, if you ask me, it is non-length dependent. So even you can, patient can present with the upper limb sensory symptoms and then the lower limb sensory symptoms, or upper limb sensory symptoms with sparing of the lower limb sensory symptoms as well. Okay, so therefore, unlike the other more common neuropathies like diabetic neuropathy, patients may report dysesthesia in the hands followed by the feet. Okay, so remember.